Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use a chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all today's guest speaker. Joining us today, we have Rayna Burdette. Rayna is a domestic violence advocate with the Haven program at Mass General in the Revere Healthcare Center. She has worked with survivors of intimate partner violence since 2016 and has been working with the Haven team for over 4 years. Rayna has experience working in residential and community-based settings and has previous experience assisting with housing, accompanying survivors to court, and facilitating groups. Although she is unable to join us today, wanted to recognize her work in today's presentation, Sandra Elien. Sandra is a bicultural and trilingual domestic violence advocate and counselor with the Haven program at Mass General in Boston. She has worked with survivors of intimate partner violence for 30 years. She previously worked as the training coordinator for the Boston Public Health Commission Domestic Violence Program. Sandra was also an assistant program director at a community-based domestic violence shelter. In recognition of Domestic Violence Awareness Month, Rayna joins us today to give a talk on intimate partner violence and advocacy in the medical setting. So please join me in welcoming Rayna.
Hello, great to be here. Thanks so much for having me. I'm really sorry that Sandra wasn't able to join today. Her experience, brings so much to the table, and I wish she was able to join today, but she was able to assist with creation of this presentation. So thank you for, continuing to acknowledge that and acknowledge also October being Domestic Violence Awareness Month. So I will share my screen with the PowerPoint presentation and we can go ahead and get started. Okay. Yes, like I said, the title of this presentation is Intimate Partner Violence and Advocacy in the Medical Setting. So of course, Haven works in the medical setting. We are kind of Mass General Hospital's in-house intimate partner violence team. Once again, I want to acknowledge the work that my colleague Sandra put into this presentation, despite her being unable to join us today, unfortunately. So we will start, and at the end also we'll have some time for questions, but as always, just feel free to put some in the chat, and if things kind of come up as I present, I'll be able to see them, or Amy also, if you could kind of look at the chat as well, since I'm screen sharing it, sometimes it's hard to see. But as they come up, I can answer them, or we can answer some of the maybe longer form questions at the end as well. So just to start off with a little bit about Haven and kind of who we are and what we do. So we have a new kind of arm of our program in which we provide services as well to survivors of sexual assault. Today's presentation will be focused on our work with and work in general with survivors of intimate partner violence, which has historically been our focus and still remains to be kind of probably our primary focus, even just like in terms of numbers. However, we have recently added more services for survivors of sexual assault specifically, separately from intimate partner violence. Our services, all of them are free, voluntary, confidential, and we also can provide multilingual services. So free also means that we don't bill insurance or anything like that, despite us being a program of MGH, which we're very thankful for. Voluntary, of course, folks can work with us kind of as frequently or infrequently as they would like. Confidential being a program of MGH, we of course abide by HIPAA regulations, as well as we don't record in the medical record for confidentiality purposes, and we have kind of some additional safety considerations that we really do our work with a safety lens at all times. So that includes things like note taking as well. And then I am monolingual myself. However, my colleagues, we have advocates on staff who speak Spanish, French, and Haitian Creole. And then, of course, we work very closely with the Interpreter Services Office at MGH to provide services in other languages. And yeah, use interpreters very frequently for our work with folks. We work from an empowerment model and kind of continue to strive to be trauma informed. Both of these are models and also are things that you're kind of always working towards. You can never say like, we are 100% trauma informed or things like that, but that is what we strive to be every day and with every interaction with folks. So some of our services, so patient services, we provide advocacy services, which is like accessing community resources. We provide counseling and emotional support, again, specifically with regards to especially intimate partner violence, as well as now sexual assault. Groups, so we sometimes have groups, or we also know of other groups going on in the state of Massachusetts. We provide safety planning, referrals. We have a legal partnership with a different domestic violence agency in Boston. So we don't have any attorneys on staff, but we can provide referrals to this legal partnership so that folks can get free consultation and sometimes representation by them. And then also at times we can provide accompaniment services. So to things like court, or I've been with clients to DCF appointments or the DTA. So we can sometimes provide accompaniment. It kind of depends on schedules and availability. And then for providers, we're able to provide consultations around cases. We don't even necessarily need to, know the patient's MRN or anything like that. We can just provide consultations. We're also happy to debrief difficult cases. We do this work a lot and are happy to always try to provide some support and debriefing situations that happen around the hospital. We know a lot of resources, so we can provide referrals, or we also can provide sometimes trainings to departments, again, kind of depending on availability and things like this. So we have advocates based out of the main campus of MGH, the Revere Healthcare Center, which is where I am now in kind of sunny Revere, as well as I have a colleague based out of the Chelsea Healthcare Center as well in Chelsea. So just also kind of before we really get into a lot of just discussions, we like to have kind of a baseline understanding of some language that you'll hear throughout this presentation. So some terminology that we like to use and that we try to use are asking for and using the correct pronouns of everybody, of course, but especially our clients. We will sometimes use kind of more general language like healthy and unhealthy relationships in terms of describing what we do. I use that language a lot, for example, when we table or sometimes are in the high school for prevention work, things like that. You'll hear a lot about domestic violence or DV in the field. Even, October is called like DV Awareness Month. This term, we also use it, I personally use it somewhat interchangeably. However, DV can sometimes be broader. So like it could include things like roommate violence or familial violence, which at Haven, just because of our kind of limited resources, we only focus on specifically partner abuse. Or like I said, sexual violence, but not necessarily familial or roommate or kind of like neighbor violence. And then IPV or intimate partner violence is again kind of what we will focus on today. And we generally use like partner to not assume the gender of the person or of anybody, as well as like assume the relationship. So that term partner abuse is kind of a more is what we often use to describe what we do. We also can sometimes say things like relationships with safety concerns, or again, to describe our work in terms of, we try to not label relationships as being relationships with abuse or abusive relationships, like without the person's It's not really up to us to label anybody's relationship. So sometimes we can use kind of some broader language, like I said, with healthy and unhealthy relationships or safety concerns. Some other language that we use, we don't use the word victim anymore, largely in the field. Oftentimes, certain systems like the police system or the court system often still uses those terms, but we wouldn't here. Same thing with, we often try to use kind of person first language to describe folks who use abusive behaviors, rather than some of the older language. Same thing with our programs that have changed a lot, that sometimes can help folks who have used abusive behaviors, and those are now called intimate partner abuse education programs. And just finally, we really strongly believe as a team that nobody is, of course, illegal. We work with a lot of folks who are without status or who are undocumented, and we try to use language, again, that describes those situations more just as, of course, humans and folks who have additional barriers, but who are undocumented. We also wanted to note that in terms of terminology, IPV, like with any field, the terminology is kind of constantly changing. So this is what we use now, and maybe, if we come back next year or in a few years, things might change again. And so we try to, at Haven, really keep an ear to the ground almost, or really listen to our clients and listen to everybody in particular about, folks, like I said, are able to label themselves or label their relationships however they would like. And then it's up to us as providers to use that language, that the person would like to use. Okay. So we also like to start off with kind of a definition of intimate partner violence. This is the definition that I use with a lot of my clients as well, and kind of how we at Haven define IPV. So what we'll be talking about today. And we define it as a pattern of coercive control by one intimate partner over another. And it may include things like emotional and psychological abuse, isolation, manipulation, physical and sexual assault, economic control, threats, stalking, and other forms of harassment, but that it really all comes down to one person kind of trying to establish and maintain power and control over another person. So like I said, this can look very different. We'll get to the types of abuse, I think, actually the next slide, but really always comes down to this power and control dynamics in the relationship. And that's really also what we're listening for when we try to screen for abuse or when doing intakes for our program. So who is impacted by abuse? So IPV crosses all boundaries of culture, race, class, religion, age, gender, and sexuality. Unfortunately, of course, I don't wish this on anybody, and I wish that it did not happen to anybody. But however, folks who are immigrants, refugees, folks with disabilities, as well as folks whose first language is not English, folks might face additional risk. I found this quote from Jane Doe Inc., which is the Massachusetts Coalition of Domestic Violence and Sexual Assault Providers, that I thought was really strong and kind of highlighted a lot of this. So, and they write, higher incidences of domestic violence in already marginalized populations point to societal factors that reinforce social stratification, power, and control. And I think that that's really important, because when we talk about power and control dynamics and intimate partner violence situations, how can we not also talk about power and control in societal and structural situations as well, that certain populations are being oppressed, and we kind of can't do the kind of interpersonal work without also working to change some of those structures. Some other stats about intimate partner violence is that 1 in 3 women and 1 in 4 men have experienced some form of physical violence by an intimate partner, as well as 25 to 33% of LGBTQ+ folks experience abuse by a partner. And then also it's estimated that 1 out of 4 LGBTQ plus youth will experience abuse from a dating partner. Abuse can occur, unfortunately, at any stage of someone's life. So teen dating violence is big, as you can see from the previous statistic, and teen dating violence actually has its own month also in February. So we really try to focus on teen dating violence then, as well as intimate partner violence can occur among elder couples or in the elder community as well. And we at Haven kind of work with folks across the age spectrum as well. So there are some or often barriers to leaving these relationships. I think that's a question that we get a lot, or that folks ask a lot in general, in terms of like, you know, kind of what are some barriers to leaving? And there are many of them. So certain things, and this is just truly the tip of the iceberg. It's very complicated and very difficult to leave a relationship with abuse. And some of the factors that might keep folks around are things like love, housing concerns, safety concerns, financial needs or isolation, mental health, shame, children, language barriers, misconceptions about intimate partner violence, cultural factors, powerlessness, immigration status, loyalty to the person, hope for change, failure of the systems put in place to help protect them. So again, really, really just the tip of the iceberg, and it's really hard to kind of sit with all of these things. And again, when we really at Haven, we try to be super trauma informed and kind of patient centered or survivor centered. And I think keeping in mind the barriers to leaving that, it's not very easy, and really just starting from a place of what the person in front of us would like to do, and if there's anything that we can do to try to help. We really see our work as being, and I'll say this also to the folks with whom I work, like, you are in the driver's seat, and I'm kind of just here to support in whatever way I can, if I'm able to. So more about kind of just the briefly about the types of abuse. So there are a lot of different types, like I said, that kind of all come back to this, one person establishing and maintaining power and control. And so some of the types are physical violence, sexual violence, emotional violence, verbal violence, financial, as well as other. So in terms of kind of emotional and verbal abuse, so emotional can be things like verbal can be things like name calling, yelling, swearing, threats. And then emotional abuse is often things like putting somebody down or making them feel like they're crazy, or disregarding their emotions, or really making somebody kind of feel smaller. And that's what we hear a lot from folks with whom we work, is this kind of sense of like just really feeling made smaller. Financial violence can include things like even opening like a credit card in somebody's name, forcing somebody to give you their money, taking money and not paying the bills that you say you're going to pay. It really looks very different in each relationship. And I know I'm kind of jumping around a little bit, but physical violence can of course include things like hitting, slapping, more serious forms of physical violence, as well as things like preventing somebody from leaving. So like blocking doorways, things like that, throwing things. And then sexual violence can include things like sexual assault or harassment, rape, as well as things like, again, when we think about it from the lens of power and control, it can include things like, preventing somebody from taking birth control, or forcing decisions about birth control, spreading STIs or STDs with, knowing in a knowing way, and so harming somebody in that way. But again, it really kind of all comes back to this like power and control focus. So really the intent of some of these behaviors. And then There are a lot of other types of abuse. Like I said, it looks very different with everyone in particular, and every relationship is different. But there are cultural factors, including religious, so kind of like preventing somebody from practicing a certain religion, preventing somebody from going to their religious ceremonies, or isolating them from their religious beliefs. Digital abuse, of course, which is huge, and I know is a part of a lot of different conversations, like even about bullying and things like that. But that could also include things like stalking via phone, or tracking somebody's location without them knowing it. So like I said, this is very, very brief about some of the tactics that somebody might use to try to establish and maintain power and control. However, like I said, it kind of all comes down to this power and control factor. Any questions quite yet or anything, feel free to let me know in the chat, or if you need me to slow down or anything like that, I can as well. I'm going to take a quick sip of water before I move on as well. Okay, so getting into a little bit of how Haven's services or how Haven's work might look a bit different in the medical setting than some of our partners in community-based settings. And Sandra and I both actually have experience working in both types of settings, of course, here at Haven in the medical setting, as well as in community-based settings. So kind of created this list when thinking about how our work might look a little bit different. And I also want to acknowledge, of course, that Haven is we're not the only medically based intimate partner violence program, even in the greater Boston area. We have many partners with whom we are in pretty regular communication also across like hospital systems. I at least have not worked for any of those other places, so can't speak to their services and can only really speak to ours, as well as myself and Sandra's experience working in the community setting and interacting with other orgs. So in Haven, or at Haven, I think one of our greatest strengths is really the access to MGH's interpreter services, as well as the CIRICOM network here. That is very, I could speak for days about how wonderful those services are, or just how needed they are, and how thankful I am to be able to access interpreter services. We also have, pretty high and varied rates of new referrals. So as I said, our work looks very different with every person individually. Sometimes our work is really short term. So things like inpatient or ED visits, we can go see folks in the medical setting, or here in Revere, where we don't have an ED or an inpatient unit, we'll sometimes still get called up to the medical appointment floors. And so sometimes these meetings are very quick. Other times, of course, those folks might choose to opt into longer term services from Haven, but sometimes we just get very varied referrals. So like I said, sometimes it's very quick, like 20-minute conversations, kind of safety planning and referring out. Other times it will be longer relationships with folks, doing some of the more like counseling or emotional support work. We also have kind of a really high level of consultation and interdisciplinary work. Of course, everybody's job, I think, around the hospital setting is really interdisciplinary. So we don't kind of only focus on or like only do this work. We also are talking to people from the medical team. We're talking to other social workers. We're talking to security around the hospital. We really like talk to a lot of folks and around the hospital setting. We also, of course, have this great access to and kind of like know some of the medical providers, so we can, of course, not being medical providers ourselves, but are able to sometimes facilitate communication, or even go see folks like while they're here for their medical visits. Kind of again, that collaboration is really high. Being in a larger institution like MGH has, of course, its pros and cons, versus maybe a smaller community-based organization also having pros and cons. And then, especially here in the smaller healthcare centers, like I said, which is where I am now, we have a lot of these community connections. So try to do some work out in the community as well, as rather than just focusing on kind of the individual clients. So versus the community setting, some community settings have residential programs or shelter programs. We do not. At Haven, we're, I think, just too small for that, frankly. And then some also have more housing specific positions or legal positions, as well as things like partnerships with local police departments or kind of other community partnerships. Again, I think that's kind of the benefit of some of the community services that really only do that type of work, like Harbor Cove, which is kind of the local one that covers Revere here. They have a residential program. They've got amazing advocates over there. And just, I think it's just a bit bigger, so can do maybe some more advocacy work. So oftentimes those are much smaller organizations, of course, than MGH or the MGB system, but possibly have like larger advocate staff. So more folks who are doing specifically DV work than us. But both of these settings most likely will offer things like advocacy, counseling, groups, and then knowledge about and kind of access to resources. Something that I've been saying a lot to folks with whom I work recently is, especially if I don't know a specific resource or can't find something for to fill a specific need, I kind of encourage folks to try to talk to their providers, to almost as many people as possible, because I'll just kind of, say, I don't know anything like that, but somebody might. So try to talk to almost as many folks as you can, or see if there's anything else that I'm missing. But hopefully both us at Haven with our resources, as well as folks in the community setting, do a lot of the same work, maybe on a day-to-day basis, but just kind of in different ways. We encourage all providers, and especially when we do provider-specific presentations, we encourage folks to screen for IPV in inpatient settings. And so here, a lot of questions that we get back are kind of like, how or what does that look like? And we suggest that you can kind of set the stage a bit. So kind of talk about like, since IPV or DV is so common, and we see a lot of folks who are experiencing relationship concerns or are expressing that they feel unsafe in their relationship, we ask everyone the same routine questions. So kind of almost like universalizing it. And here are just a few questions that are possible. So things like, do you ever feel unsafe or afraid of your partner? Does your partner ever physically hurt or threaten you? Does your partner put you down, call you names, or harm you emotionally? Which is, of course, trying to get at that like emotional violence piece. Does your partner try to control you, where you go, or the things you do? So again, trying to very briefly establish a little bit of like if there's that power and control dynamic. And then from there, of course, if folks kind of respond positively to any of those questions, we encourage providers to really offer support. So really just like, I think, empathize and offer some support if possible. So just things like, I'm really sorry that's been your experience, kind of whatever, of course, here is some suggested language, but also I would encourage you to make it your own or have it kind of be like come from the heart a bit. But so, I'm sorry that has been your experience. Thank you for trusting me with this information. I'm glad you were able to tell me, kind of getting at this, like, I'm really glad that you felt safe enough to share this with me. We unfortunately see many patients in similar situations. I want you to know you're not alone. And then I can connect you with people to talk further if you're interested. So this is kind of the, you're welcome to offer support. And then we at Haven, have the ability to sometimes have more time or be able to take things over for longer, or also screen for some of the factors, for some of the like other power and control factors. But, I can connect you with folks to talk further if you're interested in that. And so then having some materials available, even like, can I give you a phone number that you can call in the future? Or we always say, like, if or when folks are ready, we are here. We would not, of course, ask folks to like force anybody to do anything. And so that includes speaking with us. So just kind of this like offering, however you would like to get them connected with us, or however they would like to be connected with us, I guess. So here are some of the Haven referral options. This is broken down into, again, if the patient opts for us to call them, or if they opt to call us themselves, kind of in their own time. So both really start with explaining Haven services, even just briefly. Like on the last slide, you know, I'm happy to connect you with somebody to talk further if you're interested. We have an organization here at MGH that works specifically with folks who are experiencing relationship safety concerns. Would you like their number, or, you know, would you like to be connected with them? If they're interested in us reaching out to them, you know, obtaining kind of a safe phone number and a mode of safe contact is a good place to start, as well as permission for us to provide an outreach call. Again, we really like to have the patient consent to provide an outreach call. Again, keeping with that kind of trauma-informed, patient-centered care. And we will also often check in with folks as well when we reach out to them about like whether or not they're interested in moving forward, or explain our resources. We can explain also pretty well, you know, of course, what we do and what we might be able to help with or not to help with, or yeah, what our limitations are. And then after obtaining that permission, I always tell folks when providers call and they're like, how do I get you, you know, this referral? I'll share, like, we kind of can take referrals however you would like to send them. So via Epic, you can call us, you can email us, you can page us if it's more urgent. And then also, so conversely, if the patient opts to call kind of in their own time. So again, like, you know, we have folks here if you would like to get connected to speak further. But it's kind of like, oh, you know, thank you so much for listening. I'm not quite ready yet. That's also absolutely okay. Once again, kind of explaining Haven services, and then maybe providing that contact info. So again, like our phone, our email. We also have an online form now for folks that folks can fill out, and then we'll give them a call back within a few days. It's very brief. It's just kind of like name, phone number, if it's safe to call. And then once again, like the patient calls if and when they're ready. And we, again, trying to keep with that really patient or like survivor-centered way of thinking. I want to emphasize once again that if and when. It is not up to any of us to determine when somebody might be ready to speak to anybody about their experience or seek any sort of support or anything like that. It's really up to the individual. Okay, and that is actually the end of the presentation. Here are just the references. Again, that quote is from JDI, and then a lot of the stats were from either the NCADV or from our partners or another community-based organization that does amazing work in Boston. The Network The Red had the stats on LGBTQ communities. All right, and just on the questions or comments page, so that's the main phone number in Boston, as well as we have an email that if you email that email, it'll be sent to all of us advocates, and then the link is for the like interest form or the contact form to fill out to have us give you, or an advocate call you back within a few days. How I found that, just because I know it's kind of a long link, is I just usually Google Haven at MGH, and then from there, there's like a contact us form or a contact us button. And then on that page, I believe, is where like a link to the form is. So yeah, I know that I speak kind of quickly and race through a lot of info there. So I will stop sharing my screen, and I'm happy to be in communication or if anybody has any questions.
Thank you so much, Rayna. And if anyone's interested in that link that was just shared, feel free to email the Blum Center at pflc@partners.org, or any of the resources shared in that slide too. We'd be happy to share that with you. I'm going to enter that in the chat right now. So we're now at the end of the session. If you have any questions for Rayna, feel free to enter them in the chat. We have some questions about your services. Do you need to be an MGH patient in order to access your services?
That is a very good question, and does not have a great answer. I think for the time being, because we've received so much or just such a big influx of of referrals, we do prioritize and are kind of right now only taking on patients of MGH. We've always kind of prioritized MGH patients when things have gotten really busy, but because of the really high influx of referrals recently, it has been a more hard line. So we've been referring out to community-based agencies when folks call and are not patients. Sometimes, we're able to be a little bit more flexible, especially if folks like children are patients of MGH or things like that. But for the most part, yes, you do have to be a patient of MGH. However, we're also always welcome to try to find, resources to connect folks with. If we're the only number that somebody has, like, feel free to call and we'll try to find an agency that works.
Sure. And that phone number, is there any coverage during off hours when, outside of the typical work hours? Does anyone check or cover that phone line?
So that phone line is not a hotline or anything like that. So even during work hours, there's no guarantee that it might be answered. However, we often call back within even a day or the next day. I think we usually say like 48 to 72 hours. Just working here and knowing my colleagues, it's usually within a day or two. But there is no overnight or on off hours. It would be a voicemail. For kind of emergency assistance after hours, over the weekend, or on holidays, we suggest calling SafeLink, which is a 24-hour, the Massachusetts 24-hour hotline. Amy, maybe I can also just send you that number, or I'll put it in the chat as well. That is a hotline. It's run by Casa Mirna, or it's kind of associated with Casa Mirna, which is a big DV organization in Boston, but it is a 24-hour hotline. That is also the way to get connected with shelter services as well. They know all of the shelter availability of all of the shelters in the state of Massachusetts. All of the DV shelters have to update their availability through SafeLink twice a day. So when folks call us looking explicitly for shelter, that is usually the number that we will give as well, to call to ask about shelter availability. And let me send you this.
So while we wait to get that, we have another question regarding your services. Do you offer in-person or virtual services at all?
Yes. So I'm not sure exactly kind of what types of services this person is asking about, or like which of the services, but we do things these days by phone, Zoom, in person. It's really whatever the folks, whatever safety wise or schedule wise or location wise works. I think in terms of in person, we would meet like here in our offices or in the hospital setting for safety reasons. So I'm not sure if this person is asking about like in-home visits, which we don't do. But yes, in person, virtual, by phone, kind of whatever works, whatever like we can make work between the client and the advocate. So generally, kind of our intake process is that folks will call us. We'll do usually a 20 or 30-minute phone intake, and then each Monday morning, all of us advocates meet to talk about all of the new intakes from the week prior. And so then somebody or that person will be assigned an advocate who will be kind of their primary contact person for the remainder of their time with Haven. So that's kind of the intake process. And so I guess by that, I mean, clients will kind of talk to advocates individually about, again, what works for that advocate and that client. And we'll try to line up schedules and things like that.
And like for Mass General patients, information shared with Haven, is any of the information documented in the patient's medical record at all?
So the only things that we would document in medical records generally is if we receive a referral through Epic, which is kind of the medical record documentation system, we would put like a very brief note that just says that the referral is received and to contact us for more information. I think if folks have really specific concerns around even that documentation, to talk to us about it. But beyond that, we have a separate system for recording kind of our notes with clients and our conversations with clients. So in brief, no. But sometimes, of course, being in the medical system, it's kind of a case by case basis. I think with anybody and with every provider also, we get a lot of provider questions about documentation as well. We always really try to come from a place of like, every situation is different, and that, patients, also being a patient of MGH myself, my medical record is my medical record. And, we encourage everybody to like speak with their providers, and for every provider to speak with especially survivors around what they would like to be documented or not. And kind of, so I think that could be a case by case basis, but in general, no, like, it's not like how, on Patient Gateway or something, you might be able to see your conversation with other folks. That does not happen with us.
Thank you. Do you have any tips on how we can help someone who may feel financially dependent on their partner and is afraid to leave them?
Yeah, I mean, that's of course a really big and tough question. I think, and where I often start from, especially with survivors with whom I work, is kind of like, if there were any easy answers, you would have found them probably years ago. Or if there were any easy answers or like simple ones, you probably would have figured it out already. I think a lot of times folks who are experiencing abuse really try like a lot of different steps before, trying to leave or things like that. But I think in terms of, and sorry, so the question was about financial dependence. There are some resources for specifically like safety planning around financial dependence. I have kind of just a lot of ideas like that jump to mind immediately, but it's kind of a little bit more of a case by case basis, I think. So yeah, I don't know, of course, this person's whole scenario, so I'm trying to think of like general things that we would do. But in general, maybe I'll try to find, again, just like a quick resource for, there are a lot of safety planning resources online. So while we, would, and in my personal conversations with survivors around safety planning, I often do it almost as like a brainstorming, kind of like, what have you already done to keep yourself safe, and what are some things that you're already doing in this person's situation, might be like to try to, establish financial independence. And then from there, suggesting certain things. So like, of course, even just like squirreling away a few dollars here and there. Or there's an organization that can work with survivors around improving credit score. So like getting folks connected to that, or getting folks connected to places that might be able to assist with emergency financial assistance. So that, again, like if you're struggling with rent, maybe we could assist you with paying rent even just for a month or two, and then maybe you would be able to save up. So it really just depends on a case by case situation. But I think maybe in general, like getting folks connected with appropriate resources and trying to safety plan around saving some money. I will say, in terms of, leaving a relationship with abuse, I don't want to make it sound like it's easy, or that, $20 a week could lead to, complete financial independence, especially with our housing system, especially in the Boston area, and how expensive housing is and how long the wait lists are for a lot of housing opportunities. So yeah, I don't at all mean to make it sound like it's simple. But those are just a few ideas. What was the second part of that question again, Amy? Sorry.
Just general tips on a person who may feel financially dependent on their partner and just afraid to leave them for that primary reason.
Yeah, I think that's really, really common. Know that you're not alone, because that's unfortunately extremely common. Again, that financial independence or financial dependence is a really big, I mean, obviously it's a very effective way of, having power and control over somebody else. So yeah, I would say kind of trying to access other resources, seeking support where you can. And also, yeah, it takes a lot of creativity and strength, and is very much not easy. So sorry that there's not really kind of one easy answer. I will say in general, in terms of supporting folks who are experiencing violence, or, you know, if a loved one or colleague or anybody is, we really, again, really try to keep like that person at the front of their mind. So I think we as humans, myself included, like often try to jump to like, I have all these ideas and I'm going to help. And so almost trying to like pump the brakes a little bit. And again, like as much as you can, whatever metaphor works. Like I said, the driver's seat metaphor really works for me. So like really trying to think about that person there in the driver's seat, and I am kind of just here to support. So asking like, you know, I'm worried about you. I see you, like, what can I do? Or I will be here like long term if needed, or yeah, things like that. So really just trying to come from like a supportive place rather than a, I have a lot of ideas and I want to tell you about them right now place.
Sure. And I like your suggestion of like some tips about, for instance, making sure you save a couple of dollars to have to make yourself ready. Are there any web resources, not specifically financially, but that has a checklist, a safety plan checklist on things they can do to help get ready to take the next step?
Yeah, absolutely. So like I said, there are a few really good kind of individualized safety planning resources available online. I just kind of looked up one that I like, and I will send it to you right now also in the chat, Amy. But even just to get there, I usually just Google like domestic violence safety plan. And there are some that you kind of walk through like step by step. It will almost like has an online form to help walk you through and think through a lot of different settings in terms of safety planning while still in a relationship might look different. We work with a lot of folks who are still in their relationships and maybe don't even have, you know, don't have no don't aren't interested in leaving at this time or anything. And so some of those safety planning measures might include, yeah, trying to like, you know, save up a little bit of money if you can, or stay safe during fights. So even like, you know, if things get escalated, going to a living room or someplace like not a kitchen or a bathroom with a lot of like sharp corners or things that can be used as weapons. So again, things that are very individualized for specific people. But so safety planning while in a relationship, or preparing to leave a relationship, or after having left, or even like with children, with pets, it's really all different. But yeah, there are a few really good resources online that will kind of walk through some questions depending on the setting. Like I said, I'll send you one right now, Amy, or in the next few minutes.
Thank you. I don't know if there's any available, but is there any data on whether there has been an increase in intimate partner violence in the recent years, where people may be staying at home more due to COVID?
That's a very good question. I think I don't know of any kind of off the top of my head in terms of like numbers of increase of to hotline calls and things like that. However, I'm sure that I know that there was a lot in the news, especially when COVID first started around that. So I'm sure that somebody was tracking it. I don't know our numbers off the top of my head, nor do I know kind of national numbers, but I can also look into that. That's not something that I can just kind of pull up on the side here, but I can look into that and get back to you, Amy, maybe next week after I speak with my team about it. If that person, whoever asked, is interested in following up, or if you can get their info.
Thank you so much. I entered the Blum Center email at pflc@partners.org. So if anyone's interested in any of this, including the web resources, feel free to email us.
And yeah, I just sent you kind of the Amy, the plan for safety. So the resource that I like and that I often go to for safety planning and kind of recommend, I guess, is through the organization is called the Hotline. It's also the National Domestic Violence Hotline. So when you Google anything with regards to domestic violence, their number and their website is usually like the first to pop up. They have a 24-hour hotline as well as this online resource. Like I said, Massachusetts also has our own 24-hour hotline, which I would, if folks are going to call to seek support, I would probably recommend SafeLink, just because folks at SafeLink might know more of the local resources rather than national ones. But The hotline also has great, I mean, it just depends whoever you get, whoever you are, like it really, everybody will respond differently as well. So there's no one right answer. And as always, we just want folks to know, like, there is support available, again, if and when and in whatever capacity folks would like to access it.
Thank you. And I just share that link in the chat with folks as well. Right, so while we wait to see if there are any last questions in the chat, do you have any final thoughts you'd like to share with the audience, Rayna?
No, just, thank you so much for being here and for the time. I know that this topic is really hard and difficult to sit with, so I would just encourage folks to kind of check in with yourself afterwards as well about taking some space or a break if needed or anything like that. I mean, at all times, but I always tell folks with whom I work as well, especially at the end of meetings, I'm like, try to be as gentle with yourself as you can physically be. And I think we really, I always say I'm very, very honored to do this work. It's like the greatest honor of my life is to be able to speak with folks who have experienced intimate partner violence. But I know that also this is my choice, and it's hard to sit with some of this information. So yeah, take some space if needed. And also, yeah, give us a call if needed, or we know a lot of other organizations also in the area. So if it doesn't seem like we're a great fit, hopefully somebody out there is, you'll be able to find some support if you're experiencing this.
Thank you so much for spending the hour with us. You have provided some helpful resources. And for everyone who joined us today, thank you so much for taking the time. As I mentioned, this session is being recorded. If you're interested in viewing the recording, or if you know of someone who may benefit from this, feel free to share that with them. The recording will be made available on the Blum Center website within a few weeks, and that's massgeneral.org/Blum-Center. I'll enter that in the chat in a moment. That's the Blum Center website. Once you go into the website, go to the section Past Blum Center Programs, and it'll be available there. All right, everyone. Thank you so much, everyone. Have a lovely rest of the day.
Thank you. Bye.